it was an advanced oncology course kind of, and so my preceptor came and did she was a guest speaker, and she gave everybody a copy of that cell life cycle, and it was just like a drawing, and it's very, very simple though, and I think that I can relate to it better, but you may be able to relate to it better with your whatever you have in your book or other books that you're looking at as a resource. But and you do need those chemotherapy classification groups, and you do not have to memorize all of those, and I'll tell you what you need to know, because there's no way that you can learn all of that right away. I can't know all of these chemo drugs because they're coming out crazy, just absolutely crazy. So what I'm going to be doing is doing like a prototype drug for every category that we're going to be talking about. And so I will tell you what you need to know about which drugs. So we'll do prototype drugs. We've got to just pick out something that you can know really well. And then we do have some practice problems plus notes. Some people don't like the way that I did this, but that's just the way it is. But I use it for 112 and 211 because we go back to cancer, cellular issues in 211 in the summertime. So the practice problems are going to say 112 and 211 or just 112. If it just says 211, don't worry about those. And there are some notes though at the very end. I had done that a while back because some students were wondering like what do we really need to prioritize. So at the very end, the practice problems have the answers, and then right after the answers are those notes. So so don't miss that, because I think it'll help you. And they are for reference only and all that some of this stuff is. So we'll use again in the 211 course, and the math sheet does have the practice problems, and I'll let you know what kinds of problems you'll be responsible for on the 112 test, and the unit notes at the end of the practice problems document then. And so this test is going to be longer. This is the last unit test, and it's going to be longer because Ms. McCoy's psych part is online. It's totally online, and it will be included in the cellular regulation test. And so it's going to be longer, and we will kind of we'll figure it out as far as how many minutes we should have to be able to have this longer test, and the accommodated folks will have that as well. And so then you're having the legal part that is online also, and that's from Mrs. Chandler. And so her legal questions will be only on the final exam, not on this particular test. It'll just be cellular and psych. So that's enough, isn't it? So it is a long thing, and some of this I'm just putting explanations on here with your books. And I don't know if you're going to be able to see the web-based assignments. I'm going to skip over that right now, and there are going to be math problems. And that'll be the samples for the cellular test. So if it's exactly the kind of questions that you'll have on the cellular and psych test, then the problems are going to be on the first page and the answers will be on the second page. And so it should be things that you would be you'll be familiar with, and all information for the working out the problems is included on the practice problem sheet also. So that's something that you can, there's lots of math problems that you can look at. So read the notes at the end of the problems as well, just to help guide your study for the unit test. So, and then This is saying remediation quiz, the prep questions for test number 6, cellular. You don't have to do this. At one point, several years ago, we were required to do remediation quizzes or a regular quiz during that unit. But this one does include both multiple choice questions and math problems like what you would have on the test too. So it's just practice questions. If you'd like to use them to prepare for the cellular regulation part of the test, you don't have to do it, but some people like, more resources. So it is not a requirement, it's optional. And then you have the answers to the remediation questions too. So do them first, but then you can look at those and see. And sometimes people have questions. You can ask, send me a text or email to ask questions about those. I think some of those are a little bit. They're not exactly the way that our formats are, and it's not from us specifically. It's from a resource book. So that may sometimes it confuses people. So if you get confused, let me know. And I just pulled this over. This is the one that I did a while back because I'm not able to do the 112 fluid and electrolyte skills area when y'all are doing the medications and IV meds and the central vascular access devices that we all had to check off on it. And I was the one that was kind of teaching it or, to explain it and also, but I haven't been able to do that anymore, but that's the central vascular access devices are really crucial for safety for patients that are on like chemotherapy. And now all of these cancer websites, these are optional. If the list of the late effects for survivors of childhood cancers and the intro to the survivorship guidelines, you really may want to look at that children's oncology group, at least just skim over that so you'll know and understand what we're not doing. We're not delving really deeply into children's cancers, but it's a general kind of thing that you need to know. And we'll do a little more about children's cancers in the summertime. And the canceradvocacy.org, then you're probably going to be fine with my PowerPoint, but that may be a good the cancer advocacy one, and read about the About Us section and our mission, and so you can also look at the red flags in caring for cancer. Also, if there's something wrong in a cancer survivor, because if they have all this radiation and toxic chemicals in their system, it does have some long-term effects, and so they're finding more and more, and so that's one of the things that it's not going to absolutely be necessary, but if I think you'll understand it more if you look at those things that are in the red. But the reputable websites on CAM and cancer for complementary and alternative, it's really more of an integrative thing, but it's got a whole bunch of things for where you can look at for the cancer and the and we don't really want to do alternative, because alternative means that you're really not doing the standard treatment. Integrative means you do standard treatment and some things that are like acupuncture and all kinds of massage therapy and healing touch and things like that. So, and it does give you some other like herbal type of treatments, but you do have to be real careful with those because they can interact. A lot of heparin interacts with a whole lot of things, and Dilantin. The fifth, I don't even know how you're supposed to say phenytoin, whatever you call it, for seizures. But those those can interact real easily, especially somebody that's on heparin, or Lovenox is a type of heparin too. So we have to be careful and ask our patients if they are taking other herbals, because that can make a really big difference. Like St. John's wort, people take that for depression sometimes, but sometimes that really messes with heparin and a lot of other things as well. So I just wanted to sort of introduce what all of that is. So I guess what I need to do is get this popped up here. I have to check and see who is here. Come on, hematology. Okay. Let me go back and see how many people we got. We've got two people missing, and I am not sure who that is. It's 11:50 now, so I guess I probably ought to go ahead and start, because we'll have about an hour and 10 minutes for that. Are you going to record this lecture and post it on Blackboard? And well, actually the lecture is audio, but because I put my headset on and just do the whole thing, and so you can use that as a resource too. But let's go ahead and do the recording of the audio, and then you can look at it with the video. So I'm got it recording right now. So let me try again to get my share screen here. Okay, and I'm going to do slideshow from the beginning. Can y'all see? And somebody say yes or no or whatever.
Yes, we can see.
Yes,
You can see it. Okay, I just wanted to make sure. Sometimes it just mires up and messes up. Okay, so let's go with our hematology. I really think this is a beautiful picture here with our blood cells, and our you see those are the red blood cells, and we'll be definitely talking about those. These are other kind of cells too, but the red blood cells are really what we're emphasizing right now, except I'm just going to do sort of an intro with our cellular, because it's not just about red blood cells, because we got lots of kinds of cells, but the white blood cells, and we've talked about this before, like it's this says adult 4,500 to 11,000, and then there are some that are like 4,000 to 10,000, or 4,000 to 11,500. It's just going to be pretty close. Nobody's going to give you something on a test that says 11,800 or something like that. That we're not going to be picky like that. So it's just going to be in that area, that range, and it can vary with the source, like where what your facility standards are in procedures. So the percentage of neutrophils of the total white blood cells, they are the active phagocytes. So phagocyte means so cyte means cell, and phago means eat. So they're cells that eat. And it's 50 to 70% in most of the statistics there, with like if you've got 100% of white blood cells. So out of that 100%, 50 to 70% are those active phagocytes, which are neutrophils, and they are first on the scene, and their lifespan is only about 12 to 18 hours. And it's important for cancer treatment side effects and naders, which is when the neutrophils dip down between chemotherapy treatments, because a lot of chemotherapy drugs do decrease the production of those neutrophils in the bone marrow, and then they have to have a little bit of a rest, and then they have a recovery. And then the white blood cell differential, the sum of the percentages of all the white blood cell components should add up to 100. So there are all of those other types of white blood cells like lymphocytes and monocytes and eosinophils and basophils, all that kind of stuff. They have smaller percentages, of course. And then our red blood cells, you know what the lifespan is. You just took a test on this, didn't you? So how many, can somebody tell me how long that is, that lifespan?
120
108.
115 to 120 days.
Yep, that's right. And so in general, the range of the red blood cells is 4.2 to the 6.1 range as far as the number of red blood cells. The adult male has a higher number of, on your red blood cell level and your hemoglobin level and hematocrit level. And so it is going to be a little different, but just as far as just looking for a range for just adults, it would be like 12 to 18 if you want to look at that, and the men are going to be more like 14 to 18, and the women would be like 12 to 16. It depends on, again, which scale you're looking at. But if it's between like if it's a female and it's 18, that's probably a little too high for them. But the males do have higher hemoglobin and higher numbers of red blood cells and hematocrit because testosterone helps to increase the level of the red blood cells that are produced in the bone marrow. So platelet cells, we have 150,000 to 400,000, and again, that there's going to be some variation on those when you're looking up in a lab book or in your computer, with wherever you are in clinical facility. So what I do want you to know that like 12 to 18 range, but you know that the men are on the higher end and the women are on the lower end. So that if you go to the 12 to 18 and then 150,000 to 400,000, and then the white blood cells with the 4,000 to 11,000. So do know those. I think y'all have probably heard of those, but before some of those levels, because I taught y'all in the infection unit, and we talked about this at some point too. So, and if you're looking at in a lab book that has all these different levels of adults and then elderly people and all this kind of thing, you can look at that, seeing how the elderly people have maybe lower hemoglobins, and especially because the men's testosterone sort of wanes and all that, and they can have lower hemoglobin and hematocrit levels and red blood cell levels. But just what I've got on my note page, that'll be fine for you to look at. All right, so know about bone marrow aspiration and biopsy procedures and nursing considerations, and it does require healthcare provider order and assigned informed consent. So that's that. It is an invasive procedure, and so that this is something that you can look up in actually your kosher book that does have a chapter about labs and diagnostic tests. So you can look there, or you can Google it, but make sure that it's a reputable site, and there you probably will be able to see that in your in your med-surg book too. There's just lots of sources that you could look at just as what's the procedure, how does that go, how does that look. So I'm going to switch over now. So the red blood cells are are biconcave. So you see, let me see if I can do my little thing here. It's like a little laser pointer thing. So here,
I have a question.
Yeah.
When you say no about the bone marrow aspiration and stuff, are you going to go over that later? Like it's going to be on the test. That's why you're saying know it, or we just
and we're going to address that some more, but it is in your book though, it does tell you what the procedure is, and the big thing is when somebody's just going to have a CBC drawn or a potassium level drawn or something like that, you don't have to sign a paper every time. But with something that's invasive, it's going to be boring into the bone marrow, either in the sternum or the hips. So that's a big issue that it is. It is something that you've got to make sure and hold it for if the patient's got low platelets, you need to hold it longer than 10 minutes. Sometimes usually you might have to hold it for like 15 minutes if somebody has a low platelet count or some things like that. So those are the kinds of things I want you to read on in your in one of those books anyway, or check with what's the procedure of this. But I think if it's probably going to be better for you to look at your textbooks if you can do that. Some people don't like to look in their textbooks as much as online kind of stuff, but you can certainly do that if you want to. But we do have the information in the textbooks, so I would just go look that up in the index and find where it is and look at the process. So our what I was saying, I think I said this on my audio when that it is biconcave, and it kind of looks like those not off label, what do you call it, but one of the sort of generic versions of a Luden's cough drop, and it kind of has the dips on both sides. It's concave on both sides, and it's because they don't have a nucleus. And so anyway, there's lots of reasons for this though. Our red blood cells do transport that oxygen to our body tissues via the hemoglobin, and the hemoglobin in those red blood cells bind with some of the carbon dioxide and carry it to the lungs for excretion. So hemoglobin carries oxygen, and once they release oxygen into the tissues, then the tissues let the hemoglobin take the CO2 back to the lungs, so that then you could blow that out. And then abnormal numbers of the red blood cells, there can be changes in their size and shape, or alter hemoglobin content, or the structure can adversely affect health. And we're going to have a unit on, or an exemplar on our unit in 211 on sickle cell, which I think everybody knows what a sickle cell looks like. It looks like a sickle, right? So it's a real a crescent moon type thing. And then our unique red blood cell shape increases the surface area of the cells. So you got a lot of surface inside here, and then of course on the other side as well. And it does allow them to pass through really, really small capillaries. They can fold up and slide on through the capillaries without disrupting any cell membrane. And then usually this is not absolute. This is just something that I've noticed in my nursing practice, that usually when a person gets a red blood cell transfusion, like each unit of red blood cells raises the hemoglobin for about 1 point. Like if they had a hemoglobin of 8, then after a few hours, it may end up being 9. Gosh, when I was working in oncology, our patients would have like 7.5 or whatever like that, and they would get 3 units of red blood cells. And now the standard is looking to be like you just get 1 or 2 units at a time, and it seems to be more just 1 unit. And so you can sort of look up to see it might end up being 9.5, or but it's going to be something around one unit going up, unless the patient's still like bleeding, if they're bleeding internally or externally even. So it's not going to do that if they are still having a bleeding problem. So anyway, I just that was a little kind of tip that you might expect to see if the patient's it is allowing it to come up. Okay, so all right. Here are some, this is a cellular unit. So we're comparing our mature red blood cell. These are sort of cartoon-like things. So here's our concave on the top and concave on the bottom. And this is a skin cell, some type of skin cell. And this is a neuron. And it's one of those like astrocyte kind of things, but it's a star shape. Some of those neurons are star shaped, and those different body cells with different functions have unique shapes, and they'll acquire that through the cell differentiation process, and we're going to talk about that in a little bit. So that'll be probably, well, it may not be today. It'll probably be another time. Probably Wednesday when we get to this. Okay. All right. So these are some pictures of what the blood cells look like under the microscope. And there you've got cytoplasmic granules. Here, these are basophils. Those are some of the white blood cells. There's not that many basophils. They're almost like 0.8%, something like that. Okay, so and then you can kind of see the difference in these granules. These are sort of whitish, and these are sort of bluish, and these are sort of reddish. The eosinophils. And so those are ones that we'll talk a lot more about in 211 also, and then there's not that many eosinophils unless you have an allergic reaction, but that will be an exemplar in 211. And then the neutrophils, that's what we're really going to be concentrating on when we're talking about chemotherapy and radiation a little later, and so it's a poly type of nucleus. You've got 2 or 3 different areas. They're joined together, but it's polymorphonuclear cells. So, and then these have sections as well, but this one looks different. But those are the neutrophils. They're called segs or polys is what they call. They're segmented or have have more than or you have 2 or 3 areas. Okay, so here's our front view of the white blood cell, and then when you look at it from the side, it looks like a bone, doesn't it? But it can fold up and squeeze through those capillaries real easily, normally anyway. And we've got our anisocytosis. Is when this is abnormal, definitely. So this is very normal, but the anisocytosis is when the sizes are different. Like if there's not enough iron in the cell, it might end up being smaller, and if there may be some problems with it being larger than it should be. And the poikilocytosis, I hope I'm saying it right. This one has a certain little shape, and this one looks like a little ghost for Halloween. And so can be various shapes of the cells, and you can have both of them at the same time. They can be too small or too large, and have strange shapes as well. And then you can see the sickle cells, and they do sort of look like a crescent moon. And then we've got our platelets that are from metamyelocytes, and they break up and they are just fragments, but they stick together, and of course are working in our clotting. That's what they're for, is to help with the clotting and to help call in some of the other coagulation chemicals that are made in the liver, that they can make a clot together. So let's see. I have a different computer and it doesn't click like I want it to. I'm doing it with my mouse and it's not working. Okay, so our blood cell development. This is a stem cell, but it's not an embryonic stem cell. This is a stem cell that is dedicated toward becoming some type of blood cell. But it is a stem cell, and the erythroblast, if you see blast, megakaryoblast. So I said that wrong, megakaryoblast. I didn't say that. I said metamyelocyte. That's not right. It's megakaryoblast. That's what that one is called. Erythroblast, myeloblast. Okay, so normoblast, that's even more mature. And so you go through here, and this one, the monoblast goes to a monocyte, and then it can end up being a what do you call it? It's a macrophage, and so that's like a big eater. And then the lymphoblast becomes a lymphocyte. The megakaryoblast becomes a megakaryocyte, and then it starts breaking up for the platelets. And here's our neutrophil. The myeloblast can progress to basophil, eosinophil, or neutrophil, depending on what chemical stimulates it. Like if there's a warning that there's an allergic reaction going on, and with the certain chemicals are going to make it a basophil, and then the neutrophils as well. The neutrophils divide very quickly. And so then here we've got that metamyelocyte. Here's the band cell. You see the banded, and then you've got the granulocyte. All of these are granulocytes. The three here in the myeloblast area, and so the band cell here, and then our neutrophil has the poly area of the nucleus, and then the eosinophil's nucleus is a little different looking, and this one's sort of like a I guess a sort of a hat, not a half moon. It's more like a crescent moon too. But anyway, all of those are granulocytes, because you can see the granules in those in the cytoplasm. Okay, so here we go to normoblast, and then we go to reticulocyte. And reticulocyte is it is normal to have like up to 5% of reticulocytes in the circulation for the 5% of the number of red blood cells. And so the erythrocytes are definitely they actually don't have a nucleus, and they lose their nucleus because they've got to carry all that hemoglobin and stuff. And what happens with I actually read this I guess just a few weeks ago, because I was reading this in the Med-Surg book that we have changed the book for the 111 students that just came in, and it's a F.A. Davis book, and it did explain it a little bit differently, that with the reticulocytes you still have some of the ribosomal stuff in the middle of it. It's not a whole nucleus, but it's got all a few little structures still left in there, and then they can go into the bloodstream it's released from the bone marrow, and that is normal to have just a few of those in there. But with those reticulocytes can mature while they are flowing through the bloodstream. So it takes about 2 days for what is it called, the endoplasmic reticulum, or but anyway, there's some structures in there that they get rid of it over about 2 days, and then they are functional, 100% functional red blood cells at that particular point. And we're not supposed to really pop out a whole lot of reticulocytes, and we'll explain that a little bit later. But the reticulocytes can mature actually while they're flowing through the bloodstream, and they're not as easily able to carry oxygen and release oxygen and take that CO2 back to the lungs. So they do become functional, though, within about 2 days. So our red blood cell development is called erythropoiesis, and the duration of that process is about 3 to 5 days. And the stimulus for red blood cell production is tissue hypoxia. And a lot of times people think, well, since if you have too few red blood cells, then that's what stimulates the red blood cell production. Well, it sort of does, but directly it's the tissue hypoxia, because the tissues send a message to the bone marrow to get started with having let's see, what else I was saying. Stimulus for, okay. The tissue hypoxia is the stimulus. And so there are chemicals that are going to tell the bone marrow to produce some more red blood cells. So they need to do that. But in between there, actually there's a message to the kidneys, because the kidneys, y'all may have talked about that. I don't know if you talked about that much about the diabetes and all that kind of stuff. But anyway, so the tissue hypoxia thing, it does stimulate the erythropoietin, and that's the stimulus for the red blood cell production. So the kidneys are talking to the bone marrow, and then the bone marrow will produce those red blood cells. So that's sort of an in-between thing. You wouldn't really think about if you weren't a nursing student, or if you haven't had anatomy and physiology. But yeah, you probably know that the red blood cell stimulus is produced into the that goes to the bone marrow to manufacture those red blood cells. So erythropoietin is produced and released by the kidneys in response to the tissue hypoxia, and it does stimulate the bone marrow to produce the red blood cells. So when you do have kidney disease or renal failure, probably talked about that in the metabolism unit with people that have severe diabetes, and the kidneys can fail and that sort of thing. So that's the kidney disease or renal failure can really cause problems. And some of you probably have had a patient that's had chronic renal disease, or maybe even if it's acute. But you're going to see, especially in the chronics, is that they're not able to produce as much erythropoietin, or maybe not much at all, and so there's not that stimulus that the bone marrow would expect to be using to produce the red blood cells. So the kidneys are extremely crucial to the production erythropoietin and the production of the red blood cells. So the lifespan we've said is 120 days. And y'all talked about the A1C. Sometimes I've had to teach this before the metabolism unit, but now just and more recently I teach it after that. So anyway, y'all know that the A1C is when the hemoglobin molecules will attach, or the glucose will attach to it. So you'll have the hemoglobin A1C is sort of gives you an idea over that 4 months period as to what's your average of your glucose levels. So the worn out red blood cells are hemolyzed in the spleen. You remember when we say lysis, it's usually something from either an enzyme or like a mechanical burst of the blood cell. And it could be in the spleen or the liver or the bone marrow and the lymph nodes. And the body does normally recycle amino acids, which is the building blocks of the proteins. And then the heme, and then after breakdown for that, once they are broken down, especially in the spleen, the spleen sends it to the liver, mainly to the liver, to reuse it in new red blood cell production. So if there is increased lysis, that's abnormal, or if there's impaired liver function, heme is converted to bilirubin, and it can accumulate in the serum, and that can cause jaundice, the yellow skin and the sclera. So sometimes it occurs with newborns, especially preemies, and y'all are going to be learning a whole lot about that in your 113 also, because little babies don't have as mature a liver function, and they usually get caught up. But my daughter, my first child, was born like 9 days before my due date, but she was under a Billy light for several days. And then it cleared on up, but it's because when you have a whole lot of red blood cells, in the fetus has a whole lot of blood cells because they're having indirect oxygenation, is because they're not getting the oxygen directly, and so the mom is sending it to them through the placenta, through the umbilical cord and all. So anyway, so the baby needs to have more red blood cells to carry that oxygen. And so when the baby starts to breathe on its own after birth, then once that happens, the body starts breaking down those red blood cells. And if there's so many of them that the little liver can't keep up with, then that's why some of the little babies do have jaundice, because it ends up causing that, or if it is impaired liver function. It's really not impaired, it's just immature in the babies, and the heme is converted to the bilirubin and accumulates in the serum, and then they end up having the yellowish skin. I think I got all of that one. Okay, and this is where we have just some descriptions here. When we've got percentage by volume, we usually have about 55% plasma and 45% formed elements. And you don't have to remember this and memorize this. This is just to sort of picture it. And you've got, when the plasma has protein, and then we got 91% water. We've got a lot of water in our body. And then the other solutes are the 2%. So the proteins are the albumin and globulin and fibrinogen. So albumin and globulin are real important proteins. And then the fibrinogen has to do with the blood clotting. And then you got water. We know where that is. And the other solutes are like the ions, sodium and potassium and calcium and magnesium and all that. And then other nutrients and waste products and gases and regulatory substances. Some of those that like hormones or other messaging chemicals. And then our formed elements is where our blood cells are. That's the platelets and the leukocytes and the erythrocytes. And this has been through a centrifuge, so that's why this is separate, the formed products versus the plasma. And so our leukocytes, we got our 50 to 70% neutrophils. Lymphocytes are next, so 20 to 40. Monocytes are 4 to 8. Eosinophils are 2 to 4. Basophils are 0 to 2%. So that just gives you an idea, and but you don't have to memorize that one yet, but I would memorize the neutrophil part for sure. And then let's see. Yeah, okay. I had it's on the notes page, but I already just said that. Okay, so here is a pluripotent stem cell, and this is a stem cell for a blood cell. So it's just a blood stem cell, and so it is a committed myeloid stem cell now. And here is a blast. Anytime it says blast, those are very, very immature. And that if you have a lot of those in your bloodstream, then that could mean that there's some kind of a cancerous issue. But anyway, we got it to our reticulocytes, so they still have those little structures inside there, and it's products of the nucleus. This is a nucleus here, but this one's breaking up. But it does get out into the bloodstream sometimes, that we have about 4 or 5% into the bloodstream. And again, like I said, about 2 days later, it does mature into an erythrocyte that's totally functional. But for those first 2 days, it's not. But we usually have the bone marrow to spill out, or to produce and release into the bloodstream. The majority is a red blood cell, a mature red blood cell. So the process of the red blood cell production from the pluripotent stem cell to mature erythrocyte, and then the bone marrow has to have iron and the vitamin B12, vitamin B6, and folic acid and proteins to produce normal red blood cells. And red blood cells don't have a nucleus, so we already said that. And they don't divide. Since most blood cells do not divide, like in the bloodstream, they're continuously renewed by cell division in the bone marrow. So the bone marrow, they do divide in the bone marrow, but they don't divide out in the bloodstream or in the tissues. So know that the reticulocytes are immature red blood cells, and they might be increased when the client's recovering from like anemia or abnormalities like malignant conditions like called polycythemia, when the bone marrow overproduces red blood cells. And also, I think I got my thing out of order from y'all's notes page anyway. But when the nucleus of the reticulocytes shrinks and leaves the cell, the immature red blood cell does enter the bloodstream, and in about 2 days later, when all of the ribosome clusters have left the cell, it becomes a mature red blood cell. So, let's see, the number of reticulocytes doesn't increase, for when there is an anemia or something like that. So it does increase viscosity of blood if the patient has polycythemia, when you've got too many red blood cells, because there's an awful lot of protein there. And it causes risk for clotting, because it slows down the process of when the heart beats, it's thicker, it's viscous like syrup. and there's poor tissue oxygenation because you can't get all of those blood cells into the tissues easily because everything's sticky. And that can cause a short red blood cell lifespan and buildup of cellular destruction products like uric acid and gout and hyperkalemia. So our hyperkalemia, we know that our potassium is the main ion that is inside the blood cell, and then when a blood cell dies, then or if it lyses, then that can cause a hyperkalemia situation. So that's one of the abnormalities. All right, so here is the three reasons really to where we could be anemic. And so decreased red blood cell production, and then blood loss, and then increased red blood cell destruction. So if we have deficient nutrients, like we don't have the iron, vitamin B12, and folic acid, it's not going to be as efficient in producing those blood cells. And then if we have decreased erythropoietin, if there's some kind of injury to the kidney or a chronic kidney disease, and then if there's decreased iron availability, if there's not any iron stores. So that's one of the things, the decreased production. And then blood loss, chronic hemorrhage, bleeding, duodenal ulcers, and colon cancer can cause just, sometimes it does, you really don't even know that it's happening. You can have really dark, tarry looking stools, or it just is, it's just sort of insidious where you don't even realize that there's an issue. One of the things I don't like about those automatic flushing toilets is you really need to be looking at what you did and see how much you had and whether it was drier or harder or whatever, and looking at the color and specifically. Sometimes it just, of course, it's what you eat, but I don't like that when you're still sitting there and on the toilet and it flushes, and then you don't get to see what you did, because especially if you don't feel good or something, you're in one of those public toilets. I don't like that. And I don't like all that spray stuff coming up on my butt when when you haven't even got up off the toilet yet. So that's my issue of the day. Anyway, so acute trauma can definitely cause blood loss, of course. And then we've got the increased red blood cell destruction, the hemolysis, sickle cell disease, medications like methyl-dopa, Aldomet's the brand name, incompatible blood. If you get a transfusion and it's not your blood type, there can be increased destruction, lysis of those cells. And then trauma from like cardiopulmonary bypass, if there's a surgery for I guess a artificial valve in the heart, a heart valve, and so that can cause some trauma on those blood cells as well. So, and it doesn't do that to everybody, but it certainly can do it. So again, anemia is an abnormally low number of circulating red blood cells, and there'll be low hemoglobin concentration and low hematocrit, which is the number of packed red blood cells per deciliter, or it's any combination of those three. So it can be caused by blood loss, inadequate production, or increased destruction of the cells. So if you're in clinical, when your client has a decreased hemoglobin or red blood cells, don't say it's because of anemia, because that is anemia. That's the definition of anemia. So what do you think is causing that? What's the etiology? And then tell us what you think that could have caused it, according to what the history that you know of in the lab work that you look at. So anemia is a clinical indicator. It's not necessarily a specific disease though, because it occurs with a lot of health problems, and it can be genetic, it can be dietary or bone marrow problems or kidney injury or failure, and bleeding like GI bleed. That's most commonly the common cause of anemia in adults. So when I was showing this colon thing, that's where it can be very insidious, where you don't realize that it's even happening, and because you just wonder why you're so tired. And so if the anemia develops gradually, the body might compensate to a point and then masks the symptoms. So the symptoms can eventually develop if the red blood cells and hemoglobin levels are further decreased. So anemia decreases the oxygen carrying capacity of the blood, and with rapid blood loss, the volume decreases and the tissue perfusion is compromised. So, and you've got some tables and all that I had marked in your on your notes page. Okay. Oh, I should have done a spoiler alert thing ahead of time, but that really is a shark bite. So circulatory volume and cardiac output decrease, and the viscosity decreases, because if there's not enough pressure in the blood vessels, your blood pressure is just going down and down and down. So the fluids that are in the tissues try to join forces and move some of their fluid into the blood vessels, and so it shifts from the tissues to the vascular space. And then the peripheral vasoconstriction is increased heart rate and increased respiratory rate to compensate for that. And then there can be risk for shock and circulatory failure. So acute blood loss, if there's enough stored iron, there can be recovery of those red blood cells and their hemoglobin and hematocrit within about 3 to 4 weeks. Then the circulating red blood cells are of normal size and shape. So normocytic. So normo means normal, of course, and then cytic means cell. So you got a normal size and shape of the cell. And then with chronic blood loss, though, and that's what we were talking about, if it's a GI bleed, because it could end up being from the upper GI tract, like the esophagus or the stomach, or the duodenum or the jejunum or the ileum, and then it goes down, and you maybe just don't notice it. And but anyway, those red blood cells become microcytic because they're small. So that's little cells, microscopic, not microscopic, but small cells, and hypochromic. So chromic has to do with color. So if you don't know that suffix, it's chromic has to do with color, and then hypo is less, of course. So we have less color, and so that means you're pale. And that's because of depletion of those iron stores. Okay. All right, so we're going to start here with our nutritional anemias. I was trying to look at my phone for my time, because I can't see the time on my screen. Yeah, that's what I had. Like I have like 9:38 or something like that. So we're gonna go on to 10 o'clock then, and then we'll start back on Wednesday. So okay, so nutritional anemias, we got the erythropoiesis.
Did you say 10 o'clock?
I'm sorry. I mean 12. I'm sorry.
Okay.
I mean, wait a minute. I'm all mixed up.
About to go get something to eat, because if we're going to 10, I need sugar or something.
It's 1. It's supposed to be 1. Yeah, I didn't mean to say that.
1
is 1. Yeah. So
can we go earlier?
So yeah, and we'll be done at 1. So since I had to start a little bit later, we'll just go to 1. But anyway, So iron and other minerals for the hemoglobin synthesis and the proteins and that are containing amino acids for the ingredients for the erythropoiesis, and the B vitamins, B12 and folate for the red blood cell synthesis, and vitamins C and E. And then there's lots of things, probably a whole lot more, but these are the most critical. And our nutritional deficit, like inadequate diet and malabsorption of nutrients, and the increased need for the nutrient. We'll explain that a little bit. So with erythropoiesis, it's red blood cell production. Of course, that's what our definition is. And then how can you relate this to your client's diet? So you're going to need to pay attention to the listed nutrients and consult like My Plate for more details for addition of those nutrient-rich blood building foods for anemic clients. So, and y'all have used this before when we were in 111 with the choosemyplate.gov. There's lots of other sites, but Choose My Plate is really a good. Gives you lots of links to other resources. All right, so iron deficiency anemia is our first exemplar here. It's the most common type of anemia in children and in adults. And then it's the most common nutritional deficiency in children too. So it can occur because of blood loss and increased demand for blood production and poor nutritional intake and the poor GI absorption of the iron. So this is sort of redundant, but that's the way it is. So with that blood loss at the on top there, the 9 to 11% of adolescent females have anemia, but primarily due to menorrhagia or menorrhagia. I'm not really sure how you're supposed to say that, but anyway, because of they have really heavy periods. And that's causing them to have blood loss, more blood loss than they're being able to keep up with. And then excessive iron loss that results from chronic bleeding, the usual cause of iron deficiency anemia in adults. And it might be from slowly bleeding peptic ulcers and GI inflammation and hemorrhoids and cancer. Menstrual blood loss is the most common cause in adolescent and adult females too. So you might also have inadequate dietary iron intake and malabsorption syndromes or increased iron requirements. And that's what we didn't even mention the reasons for the iron requirements, but it's like pregnancy and lactation. You need more, you need to be really nourished. You're not going to go overboard with it, but you need to make sure that you are having enough iron-rich foods, and your hemoglobin is checked periodically during pregnancy. And lactation if the patients had problems during pregnancy too. So children and pregnant women can experience pica. I don't know if y'all have heard of that before, but pica is an unusual craving for non-food items. It's like ice and paint and dirt and clay and laundry starch, all kinds of things that are not food that the person craves. And so it can make children susceptible to lead poisoning, because if they are deficient, if they're not having a iron-rich diet or not enough iron-rich dietary items that they eat, then they're going to just eat whatever they see, and it can be especially like peeled paint off of a wall, and there's still older buildings that have lead in their paint, and so you just wouldn't want your kids to eat, whether it's lead laden paint or not. You don't want them to be eating that kind of thing like pica. It could certainly be damaging to them. So the risk factors, the clients with the poor nutrition and female clients in childbearing years and poverty are definitely risk factors. So poor children are more susceptible to lead poisoning, which we know that's a sad fact now. And but it can be from the older housing with the lead paint. It can lead to learning failure. Lead absorption increases in the anemic state, and that's really horrible, because really the the hemoglobin is hooking up to the iron. I mean, to the lead instead of the iron, because they're not having enough iron, and the lead can really damage the brain. And you can't. There are some of our minerals that you can't, like, well, with iron you can actually have a medication that they call it a chelating agent, which means it binds to the iron, and it can pull the iron into the bloodstream, and you can actually get rid of it through the feces with that. But it does not, that we don't have any medication to bind with lead. So lead just it will just accumulate in the child, or it could be adult too, but it can really mess with the developmental issues with the children, and that's just horrendous. And that issue with the Michigan deal, when they had all that lead in the water and had not really paid any attention to that. So anyway, the lead absorption increases in the anemic state, and Hispanic and African American and Native American children are at risk for increased inadequate iron take. So 2/3 of the adult iron is in hemoglobin, and 1/3 is in the bone marrow, in the spleen and liver and muscles. That's the iron stores. So especially the liver. The liver is the major storage area, but bone marrow and spleen are they participate too. And the iron stores, if they are depleted first, then the hemoglobin stores become depleted as well. And I'm not going to make you memorize those 2/3 and 1/3 and all that kind of stuff, but that do remember that the liver's really basically the largest storage area for the iron. Okay, so this is our signs and symptoms, and it's this, we're talking about pallor of the skin and the conjunctiva, which is the lining of your eyelids, and mucous membranes and nail beds as the blood's redistributed to those vital organs and away from the peripheral tissues. And the skin might be cool and clammy too, because you tend to be cold when you don't have enough hemoglobin in your system. So increased heart rate and increased respiratory rate can, that's compensatory mechanisms, and you're trying to increase the cardiac output and the tissue perfusion. So angina or angina is chest pain, and it's due to decreased perfusion of oxygen to the myocardium, which is the heart muscle that is pumping. It's doing the pumping for us. And then fatigue and dyspnea on exertion, DOE, and again, I keep saying, it's not doe a deer, a female deer, it's dyspnea on exertion. And y'all have had your respiratory unit a while back. And there can be night cramps, because you've got to have oxygen in your muscles. And then tissue hypoxia does stimulate that erythropoietin release and increases that red blood cell production in the bone marrow, and it might lead to bone pain. Because if there is a lot of stimulation and a lot of erythropoietin, the marrow in the bone marrow, they might have so many that they have produced, it can cause it packing in the bone marrow, and the bones are really not going to stretch and go anywhere, and so it causes pain sometimes with red blood cell, especially if the patient is on an erythropoietin shot, which is recombinant DNA technology. It's the same ingredients, I guess you would say, that it would do for our own erythropoietin that's produced in the kidneys. But it's if you do take those shots and they work too well, and you get real packed bone marrow, then the bone pain can be very severe. I've had to to help treat patients with opioids with those kinds of bone pain. It's not just a little ache; it's horrendous. So anyway, so the cerebral hypoxia can cause headache and dizziness and dim vision, and then heart failure can develop when you have severe anemia because your heart's just wearing out, and it's not going to it's not going to be able to pump anymore. It's just all finished. All right, so iron deficiency anemia, then the clinical manifestations, any anemia is going to have this manifestation as pallor, you're pale, fatigue, and irritability when you just don't have any energy and you want to do something and you can't do it because you're so awful tired. Your manifestations too, the long term, nail bed deformities and clubbing. And that's one of the things. Clubbing is because of hypoxia too, isn't it? And so the growth retardation in children and developmental delay in children and tachycardia, and then the systolic heart murmur when you hear the swish from that decreased blood viscosity when it goes through so easily and it's not viscous enough. We don't want it to be too viscous, but when it's not viscous enough, when you don't have as much hemoglobin going through your system, then it does cause a swish. That can be a reason for a heart murmur. And so it is the most common anemia through the world, especially in women and older adults and people that don't have good diets. And all except growth retardation and developmental delay can apply to adults also. And even though the body recycles and stores the iron, and there are small amounts are lost in the feces, and you need a steady iron intake for replacement, because we do recycle a lot of our ingredients from those red blood cells that were hemolyzed in maybe the spleen, but some of it does go out through the feces, and not all of it is stored in the liver or the bone marrow and all. But anyway, we still need continuous iron intake. And so our diagnosis, that we look at CBCs in which shows decreased red blood cells, or those microcytic, the small red blood cells, poikilocytosis, they're malformed. And some of the other tests are ferritin, and that's a protein that stores iron mostly in the liver. And then there's transferrin, which is a plasma protein. It transports. When you see trans there, that means it's going somewhere, right? It's taking it somewhere. It's taking the iron somewhere. And then when you see the ferritin, you have FER or FE, and you got ferrin in that when you're going to see FER or FE, remember that's iron, that's got to do with iron. If you see something like that on your NCLEX or your Kaplan tests, and you don't really recognize that whole word, but you do realize that it's iron, FE or FER. And then it's going to be transporting that iron to the liver and the spleen and the bone marrow for storage until it's needed. And then the total iron binding capacity is the amount of iron that comes in the plasma if the transferrin is saturated with the iron, and if not, the TIBC will be increased, and it indicates decreased iron levels. That you have to look at that for a while to understand it. And I'm not going to make you memorize that, but I think you ought to look at that real closely to understand that there are several tests that they usually do, like an iron profile, and it takes on all of those. Like you'd have an iron level, and then you see your ferritin, your transferrin, ferritin, and that TIBC. They all go together to try to predict what's going on. And sometimes people have multiple problems, and it's not just related to one of those issues, the transferrin level or the ferritin level. Some people have both of them, and then it can be very confusing. But anyway, the chronic iron deficiency can result in brittle spoon-shaped nails and chelosis. That's on your notes page. It's cracks at the corners of your mouth, and a smooth, sore tongue. That's called glossitis. And then the pica. Those are those manifestations. Okay, so here we go with our iron. Our best source of iron is lean red meat, and iron can also be found in chicken and turkey and eggs and cereals, and that has to be fortified cereals. So iron absorption is enhanced by vitamin C. I do want you to know this for real sure. Of course, I have it in red and underlined in a exclamation point. So we've got it is enhanced by vitamin C. My nutrition teacher, we had a nutrition course when I was in college, and she was a dietitian at Grace Hospital in Morganton, and she would tell us that you should have iron-rich foods or iron supplements with like orange juice or something that has vitamin C in it, or you could really take a vitamin C pill with that. And in the opposite way, it's inhibited by tea or coffee. So if you're taking or you're having tea and coffee at that particular point while you're trying to take a supplement, or you're really trying to enhance your iron absorption, then you need to be drinking your tea or coffee at another time. And then the deficiency can result from blood loss or poor GI absorption of the dietary iron and an inadequate diet. So we've already mentioned that several times. And our red meat, organ meats, egg yolks, kidney beans. Okay, so we can go on to our vegetarian folks. Kidney beans, leafy green veggies, raisins, blackstrap molasses. I'm not going to explain the blackstrap molasses to you, but I do have. I went to Wikipedia too, because it was really the best explanation about that. So anyway, click on that, and it's really interesting. So if you cook in an iron skillet, it can. I actually heard that from the Red Cross, because when I got out of college, I was doing every 8 weeks donating to the Red Cross, and I ended up having a low hemoglobin, and so I wasn't able to donate that time, and they gave me a sheet that said cook everything you can in an iron skillet, because it does come off of the skillet, and you can swallow it and absorb it and all. And then I had this Mr. Wizard thing. My kids went to Horizons Unlimited at right behind Knox Middle School. We live real close to there. But anyway, there was a Mr. Wizard presentation type thing, and then the man had a box of cereal and put and it was fortified cereal, and put it in a blender and chopped it all up, and it was just in a powder. And he took one of those horseshoe magnets and stuck it into the blender and pulled out had all of these fine iron filings on the magnet. And so he proved that yes, it was fortified and there was iron in that, and yes, you really could see it if you want to do that with your kids or something, to do it in a blender if you have a magnet like that. It's really pretty a cool experiment. And only 5 to 10% of our dietary iron is absorbed. Isn't that interesting? So that's not a whole lot. And then menstruating women can become anemic, and iron sulfate supplements are what they usually use. And you take between meals for best absorption and less GI distress. Sometimes if you do have GI distress, it's better to go ahead and eat with it, but you don't want to be having milk products either. You don't, because it's not going to absorb well if you take it with meat product. milk products. So if it's severe, the iron supplements can be given IV or IM, and iron dextran by Z-Track, and then the IV route can cause the infusion reactions too, which are cardiac effects. And there are new iron supplements available that don't have a risk for cardiac effects and are much safer to administer. And you still need to monitor the patient's vital signs because somebody could have a reaction to it, but it's not nearly as high a risk as that iron dextran was. And then you're going to monitor the patient during the iron infusions. And also children. Yes.
Okay, you said with the iron supplements, you said no milk because it affects the absorption.
Right. Don't take it at the same time. It's not like don't drink milk at all. Just don't take it at the same time.
Okay.
Yeah. And then the tea and coffee also can be a problem. And then children or adults that can't swallow pills very well, or don't want shots, you can take oral liquid iron supplements and dilute them with water and sip with a straw. Have the patient to sip with a straw to avoid staining your teeth, because it can really mess up your teeth. And so definitely write that down. I don't know if I had that on the notes page. I didn't have that on there, did I? I think I just scribbled it on there to make sure and tell you that, but using a straw and diluting it with water is going to make it easier on your teeth. So if you're not able to do the pills, so I think we're about at the end of this particular one here, and let me get off of here. And I do want you all to look at those the web-based assignments, because there is one about iron deficiency anemia, and on the HESI, and then also your you have you can work with some other people on that other one that has to do with hematopoietic injectable kind of medications that will increase the white blood cells or red blood cells or platelets. And so you can work with a group of people and do that, as long as everybody participates in it and just turn in the results or the completed document to me, so that you will get that done. I just wanted to mention that to you, that you do have those assignments, and it'll help you on your tests. Okay, so we're all set now, and then y'all I will see you on Wednesday.
Can you tell me again about those assignments? You're speaking really fast.
It's on the on Blackboard. It's a folder on Blackboard, and it says web-based assignments, and one of them is the HESI, and then the other one is, so you were not in with our 111, were you? Have you done some HESIs with Miss yeah, because you didn't do it with Miss King, right? She didn't do any of those HESIs. So yeah, and so you do need to get a HESI account, or have you already done that? Have you already done it? Because it's with it's in the book list, and it's with it's Elsevier. It's evolve.elsevier.com, and I think I put it on the web-based thing if you can't find that, but you can just buy it directly from it's a subscription, and it should last for 2 years. So I'm trying to think how we're gonna do that one, because I think if you just go ahead and purchase it, then I can give you a code So maybe I can send that to you in just a minute, because the one that I just started this last or this semester. So I think I'll do that. I'll get that one
I could just
started up for you. Hmm?
just send you an email. I'll try to look it up and try to subscribe to it and get it.
Okay. Okie doke. So,
Miss
all right.
Beaver,
Mhm.
just to clarify, we don't have to pay for HESI again this year, do we? This semester?
No, you don't have to. You don't. It's supposed to be for 2 years.
Okay.
Yeah. It is. It's Some of you all might be in a different group. As long as you might have to renew it if you need it in your very last classes or something. I don't know if Ms. Hyde's going to require that or not. But at this point, I think everybody ought to have that. I know that Shaniqua, is that how you say? Is it Shaniqua? Is that how you say it? Like, okay, yeah. People spell it a lot of different ways. So yeah, it's good to see you. I hadn't even got to meet you. So okay, but yeah, I think I'll go ahead and get one of that this year. So I'll try to send that one to you. So yeah, you should not have to buy it again. Not at all.
So where do I go to even find this? It's on Blackboard.
Let me look. I'll see here.
Web-based assignments.
Yeah, web-based assignments. And let me make sure that it does say, go to evolveelsevier.com for HESI patient reviews, and then go to the adult health. Yeah.
Okay.
And I'll look it up for that number from my 111 class, because I think that would be the easiest way to do that. And I'll just send that to you then. What is your last name?
Jones.
Jones. Okay. I'll just get that and send that to you right now. Let's see.
Miss Beaver,
Mm-hmm.
are you okay with us logging out? I have to go to work.
Oh, you're fine. Yeah, go ahead. Yeah.
All right,
I'll just send it to you.
okay, thank you.
Mm-hmm.
Thank you again.
No, y'all can go ahead because yeah, I know we went over. We just got to, the overlapped with the test and everything. So yeah, you're fine. Yeah. Oh, yeah, you're good. You're all set. You too.